wants to chime in as well.
Yes. Miles, what time is it? You are in Lubbock now?
Yes, it is 10 till 6.
Oh, it's too early.
Well, yeah, it's almost what, 8 o'clock with you?
Yes, almost 8.
Yeah, perfect. So when do y'all eat dinner? 9?
Yeah, today will be 10. Okay. Miles, we need to wait a little bit,
Okay,
and then we will start.
sounds good.
Okay, okay. How about your trainings?
They're good. My doctors are doing very well, and I have no complaints at this time.
Really?
Yeah. How was your
Ah,
running?
tudo bem, boa noite.
Miles, I'm with a big labral lesion in my hip.
Uh-huh. Oh,
Yes, it's too difficult, too hard to train, to running.
oh, I'm sorry to hear that.
Yeah, yes. It's a consequence of everything I did before.
Mm-hmm. Yeah, I've got a little bit of plantar fasciitis in my right heel that is taking time to heal. It's been about 6 months,
Oh,
but I can still swim and I can still bike. So
oh,
I've got an Ironman that I'm training for that is in November. So hopefully I can get back. I can run some. It's slightly uncomfortable, but that's it. So, you know,
no, congratulations for recovery.
yeah, yeah.
Oh. Then, Miles, maybe 10 minutes we will start.
Okay, perfect.
Okay. Do you know the steps? The here in the pain wine. The wine is a one presentation when you start talk about one wine
Yes.
that is important for you. I'm very curious about your wine you select.
Well, I'll tell my story about the wine when my enjoyment of wine when we get started.
Okay.
Yeah.
And before you started your medical presentation,
Mm-hmm.
you make a toast with you. Yes.
Yeah. Unfortunately, I have to exercise later. So
Really?
I'm gonna toast
No. Yes.
with Diet Coke.
Very good. Very good. It's okay.
Otherwise, if I have too much wine, I may fall off my bike.
Yes. Probably yes.
Yeah. Sandra.
Yeah. Sandra is coming.
All my friends are going to be on this.
Yes, probably yes.
Nice.
Paula stay with you in the FIP exam the last weekend, the last FIP exam.
No, she wasn't there. Amelia was supposed to come, but she wasn't able to. So I guess we'll meet up in Antalya, Turkey, in October for the World Congress. So Leah was there. And of course, Fabricio and Charles and let me see, Francisco and trying to think.
Paulo Renato, probably.
Yeah, Paulo. Yes.
Paulo.
Yes.
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 Tiago.
Yes.
Yes.
So it was good. It was fun.
Yes.
And I'm trying to remember, what was the name of our colleague that traveled with you to Lubbock?
Rosanna.
Rosanna. Uh-huh.
Rosanna, yes.
How is she?
She's good. She's working in Brasilia, living there. And we not work together more, but we still have a friendship yet.
Good. Good. And Dr. Rax was even there in Orlando the previous weekend. So.
Really?
Yeah, he taught a little bit and helped give the exam, but he's kind of not as mobile as he used to be.
Okay.
But he's still trying.
Okay. When the exam happened, the I don't remember, 2 weeks ago. Huh?
It was
yes.
13th. Yeah, it was a couple of weeks ago before Easter. So it was on the 16th. Well, actually, yeah, it was on the 16th.
No.
Was the exam. So the next one's in Budapest, of course.
Exactly. In the winter, I'm go there in Orlando. In my vacation home.
Really?
I was there. Yes. Yes.
I don't have a vacation home. I'm poor.
Oh no, my friend.
I am rich in colleagues from around the world.
Yes, I'm sure you are.
Yeah.
How about your family, your ranch, your wife, look, Sandra?
Yeah, we're all good. Hi, Sandra. We're all good, and the ranch is still the ranch. There's still scorpions and rattlesnakes and jackrabbits and cactus.
Okay. And your daughters?
They're good. They're getting older. We're about to be empty nesters. So our youngest is going off to college in the fall, and our oldest is living in Kansas City, Missouri. Hey, Andre. I can see Andre's wine, at least his glass.
Yeah.
See, I've got Diet Coke, Andre, because I got to get on my bike later. Too much wine, I may fall off.
Glad for you.
He is the worst example for us in pain wine, Andre.
Yes, I know. Too fit.
Andre, did you get those chapters?
Yes.
Okay.
I have now plenty of pics, so it's getting beautiful. But I need to see. I need to have the how many lines, how many characters, and so on.
There's really no restriction. So other than focusing on those specific sections in each chapter, I'll send you some more stuff.
Okay.
So there's a lot of overlap on other chapters. So
perfect.
Cecília, tudo bem?
Tudo bem.
Tudo bem. Sandra, habilita seu som para falar boa noite aqui para o Maios, aqui, ó.
Acho que agora eu consegui. Hi, Miles. Nice to see
Sandra.
you. Hi, guys. Missed to be with you.
What's that?
I missed to be in Orlando this year.
We'll have more times this year, so.
Are you coming to LAPS, to Latin America?
No, I'm not able to because I will in June. It's in June, right?
Yep.
Yeah, I'll be in Budapest one week and in the Bahamas another week. So I would love to be with y'all, but then I wouldn't have a single day that I'd work in June.
Anyway, you can come in August, I think. It's going to be the Sobramid Congress. I'll be there too. So
All right. I've
you
got
are
it.
welcome. And I would
Yeah.
like to embrace you once more.
Oh, great. I've got it on my calendar. So I've set the time off for that.
Save the date.
Save the date.
We are waiting for you.
Cool.
I'm gonna close the mic here.
Okay.
So
Okay.
it was nice to hear from you once
Good to
more.
Thank you, Sandra.
Thank you, Sandra.
I made an upgrade. Pain, cheese, and wine.
Yeah.
I joke with the fellows when they start whining. I say, do you want some cheese with your whining?
Perfect.
Let's say I got to do something real quick, okay? 30 seconds.
Okay, okay. Thank you. Vamos começar mais na hora, né, pessoal, por causa dele.
Boa. Ele tem que pedalar ainda.
Ele vai pedalar ainda, rapaz.
Vai pedalar. É um pedalão. Pedalão de bicicleta.
É. Quando eu conheci ele, ele era monoatleta, que nem eu. Aí ele evoluiu, ele foi para outros esportes, né? E eu fui me ferrando com o único esporte cheio de impacto, né? Agora, para se tornar multi-esporte, André, eu garanto que ele tem mais tempo livre do que nós.
Rapaz, com certeza tem.
Eu também acho.
Mais tempo livre que eu tá fácil.
Sim, com certeza. Que nós aqui. Deixa eu habilitar o microfone dele. Deixa eu habilitar aqui, só um minutinho.
Okay.
Okay. Miles, I need to make some announcements before you start.
Cool.
And I will introduce you in Portuguese, my friend.
Sounds good.
Okay. I let you know when you need to you start. One moment.
Perfect.
Bem, pessoal, eu queria começar aqui a o nosso Pain Wine de novo, de hoje, tão especial, com a presença do Miles Day, que é uma referência mundial aí em terapia de dor, intervencionista, e é um grande exemplo de trabalho, enfim, de tratamentos que ele promove aí no mundo afora, com grandes evidências de sucesso. Então, é um professor do programa aí do IP, né, também faz parte do board de examinadores do IP, trabalha na Universidade da Texas Tech. Eu visitei lá algumas vezes, é uma pessoa muito querida. Ele tem certificado também em tratamento de dor de cefaleia e dor cervical. Foi editor, ou ainda é um dos editores, na verdade, do Pain Medicine e Pain Practice. Então é um grande prazer tê-lo aqui conosco. Tem mais algum adjetivo, André, que você queira falar dele aí para nós, hein?
Iron Man.
Iron Man, yes. E eu queria agradecer a todos aqui presentes nesse dia. Nós hoje também vamos ter um sorteio de uma inscrição do Congresso Brasileiro da Sobramide, e eu volto a falar dele. O Congresso Brasileiro vai ser realizado do dia 3 ao dia 5 de agosto, no Hotel Bourbon, em Ibirapuera. As inscrições já estão abertas, é o maior evento de dor do Brasil, e vai ser um sucesso mais uma vez, como foi outras vezes. Então, gostaria de convidar todos os presentes e todos aí de dor, dos tratamentos de dor. Lá vamos ter uma sessão do Pain Wine também, com discussão de casos clínicos, então vai ser bastante interessante. Esse evento aí que nós estamos hoje, tá, do Pain Wine, ele é um patrocínio aí da OMED, da GenesMed, que nos ajudam na plataforma, que também é mantida pela Sobramide. Tá? As aulas ficam gravadas depois e disponíveis no YouTube, no canal do Pain Wine, através da plataforma Vambu. E no próximo Pain Wine nós vamos ter também outro convidado internacional, que é o Golov, o Stanley Golov, que vai falar do Mild Procedure. E como hoje também o procedimento aí que o Miles Day vai nos falar, que é sobre o Basivertebral Nerve Ablation, né, a basovertebral, ablação do nervo basovertebral, não é um tratamento corrente ainda no Brasil, mas é muito interessante. Eu acredito que brevemente nós vamos ter esse procedimento para fazer. É um procedimento de grande evidência de sucesso. E na semana que vem, no mês que vem, também vamos ter a apresentação do Mild Procedure, que é um procedimento também que ainda não temos no Brasil e é bastante interessante. Tem mais alguma coisa, Andrezão, que você tem em mente aí a falar para a gente aqui?
No, let's go.
Let's go. Okay. Good evening, Dr. Miles. Good evening, everyone. First of all, I would like to thank you, Miles, for sharing your free time with us. I know how busy you are, so thank you very much, my friend. It's always a great pleasure being around you. I'm sure we will learn a lot with you tonight. You are welcome to start whenever you want, and they are curious about your wine you select. And before you start your medical presentation, you make a toast with your Diet Coke, my friend.
Sounds good. Okay.
Thank you.
Thank you. Thank you for having me. I'm going to share my screen. Here we go. Can everybody see that?
I love it.
Okay.
Yes, very good.
I want to thank everyone. Sorry for the reflection on my glasses. Thank you for inviting me. I think of all my travels, aside from Hungary, Brazil is probably the second most country that I visited. and I love coming to Brazil to see all my friends. So it's titled Malbecs and Basivertebral nerve ablation. So pretty straightforward. So I don't have any disclosures. And our objectives, well, we're going to spend 10 minutes talking about Malbecs. I actually learned something about Malbecs from Jose Luis when he visited me, my family, my clinic several years ago. So I learned something from him. We're going to identify the basivertebral nerve ablation procedure. We'll look at anatomy and physiology of the targets, because I always say anatomy is very, very important. We're going to define the different types of modic changes. We're going to look at indications for basivertebral nerve ablation, BVN, look at contraindications. We're going to survey the procedure, categorize adverse events, and also inspect the current literature. So, Malbecs. My story with wine is that before I met my wife, sad to say that my extent of wine was probably Behringer's White Zinfandel. And that is a terrible wine, I have come to realize. One of the first dates my wife and I went on, we went to a local winery, because actually in Texas, because especially West Texas, because of the dryness and the lack of humidity, it's a good place to grow grapes. And a lot of them are more varietals. So there are about 3 different or 4 different wineries in this vineyards in this area. And I asked her what she wanted, and she said she'd like a Merlot. And I'm thinking, what the heck's a Merlot? I'm a beer guy, so I'm thinking beer. And she's thinking Merlot. And I actually felt a little uncomfortable walking up to the bar asking for a Merlot. And I said, I'd like a Merlot and whatever else I was drinking. And so they served me. I'm like, okay, there is a Merlot. I wasn't embarrassed anymore, but I've learned a lot about drinking wine from my wife. And over the years of my travels, I used to like sweeter wines, and I like Cabernets, but then I got hooked on Malbecs. I think it's a great wine. And so as I was preparing this, I learned all about Malbecs. So it was originally from France. It's a thick skin grape, and it's actually a cross between 2 esoteric varieties that are from Montpellier. And I'm not going to try to pronounce these French words, because I totally ruin it. It's like me trying to speak Portuguese. The majority of French Malbecs are found in a small town by the name of Cahors, which is near Bordeaux. It was a blending grape in that area, so you see it as a blend in Bordeaux's top 5 wine grapes. But unfortunately, because of resistance to weather and pests, it never blossomed in France. So it moved across the Atlantic Ocean to Mendoza, Argentina, where a French botanist planted it. I guess this city in Mendoza, their mayor said, plant me some grapes. And they started planting Malbec grapes. And now Argentina saved the grape. Thank God for Argentina in that sense. So characteristics, you asked me to drink a glass of wine. I learned when we took a trip to California that when they pop the cork, you shouldn't take the cork and sniff it. That's called a cork dork. So you're supposed to inspect the cork and make sure that the wine hasn't gone all the way through to the top of the cork so that it doesn't sour, because air can get into the bottle. But I've learned with Malbecs, there's kind of a variety. As I'm drinking a Malbec, I'm definitely not going, this tastes like raspberry, or this tastes like blueberry. My palate is not good enough for that. So as far as the fruitiness, there's black cherry, pomegranate, plum, raspberry, and so, but then there's other hints of smells and tastes. Don't ask me to tell you about these. I'm not a sommelier. But you can see here that, the acidity is medium, the tannin is medium, and it's slightly cool to drink at 69 degrees Fahrenheit or 21 degrees centigrade. There are some blends. In France, there's the right bank Bordeaux and mixed with Merlot. And in Argentina, it's blended with Bonarda, which is a regional grape. So you've got your Malbecs and you've got your blends. And so don't ask me to, if you ask me to take a pop quiz on this, I'll get it all wrong. I'm just kind of reporting, I'm learning as we go. So when you look at the tasting by region, you can see in cooler climates, you see it's more of a black cherries, like in France, Patagonia, Argentina, and even in Washington State in Northwest the United States. And as you get to warmer climates, you get to the blackberries. So in Argentina, the main fruit is blackberry, plum, and black cherry. But in France, it's slightly different. And don't ask me, I could not tell you if a Malbec was from Argentina or France, because I'm not good at smelling the nose and the body and the after, the finish. I'm not real good on that. Ask me to drink beer and tell you about beer, I'm all good. So I always have to ask my wife, am I gonna like this? And then she tells me. So thank God for wives when it comes to wines, at least for me. So, so what are the wine regions? I didn't realize, or now I realize that 75% of all Malbec vineyard acreage is in Argentina. And you can see here, you guys, over here, and here is the Mendoza region of Argentina, and these are a lot of the vineyards. So Argentina has about 75,000 acres of vineyards for Malbecs. France, 15,000 in the US. It's mostly on the West Coast in California, Washington, and Oregon. There's a lot of good wines actually that come out of Oregon. And then Chile is about 2,500 acres, South Africa, 1,100, Australia, 1,100, New Zealand, only 200 acres. So just know that Argentina is where most of the Malbec wines come from. Now, of course, we got to figure out, I'm not sure what these blue lines are appearing are from, but meat pairings, got to know what to eat when you drink. So with the Malbecs, looks like that's Rodrigo's making blue marks, is dark meat poultry. So of course, duck, lean red meat. So think of duck, chicken, lamb, beef. I haven't eaten too much ostrich, but I guess it's good. Buffalo, I like buffalo, and pork shoulder. As far as spices and herbs, pairing it with parsley, sumac, thyme, rosemary. I am not a chef. I don't cook. I'm really good at doing the dishes. So if you make me dinner, I'll do your dishes. And I don't care how many dishes you get dirty, I'll clean them. Cheese pairings, cows and goat's milk cheeses. Vegetables, mushrooms, roasted vegetables, green and bell peppers, potatoes, and as you can see. So I guess I mostly, when we do drink Malbecs, we're talking duck is, and sometimes pork. So now, since I went through all that and we have a bunch of blue streaks on my slide, not sure how that got there. I'm going to toast everybody with my Diet Coke. And so hopefully soon together we can enjoy some Malbec, and then you can teach me about all sorts of Brazilian wines soon. So cheers.
Cheers.
Okay. As I'm looking at this screen, I just realized I spelled basivertebral wrong. It's basivertebral. So I get a mark for that one. But this is a technique that even I haven't been trained in this yet. In the United States, it's very strange. Well, it's not strange, but a lot of the new companies will not train you unless you can provide them with 3 patients, the names that you feel that this would be an appropriate procedure on, which is really weird. So industry somewhat controls who they train. Which I don't agree with that at all, but that's just me. So basically, this is a minimally invasive spinal procedure which targets the basivertebral nerve. I'm going to just say BVN, which is responsible for carrying nociceptive information from damaged end plates. So this is an entity that just recently in studies was postulated as a source of chronic axial low back pain. So anatomy and physiology is always important. Before the a lot of times before I knew about the basivertebral nerve and vessels, you would look at an MRI and you would always see in the posterior part of the vertebral body an indention, and nobody really knew what that meant. But then the further you look at these, you go, oh, that's the nutritional supply of the vertebral body and also the nerve supply. So the sinovertebral nerve comes from the ventral ramus, as we all know, enters the spinal canal in the posterior aspect of the vertebra, and enters the vertebral body through the basivertebral foramen. It's located in the midline, the posterior vertebral body, and it's an entry point for the neurovascular bundle, consistent with the basivertebral nerve and the basivertebral vascular plexus. So that's the nerve and the vascular supply. Now it's typically in the posterior half or 1/3 of the vertebral body, and it kind of forms a trunk of cluster fibers that migrate cranial and caudally. It kind of looks like a tree. So you got the tree coming in where the BVN and the vascular plexus is, and just kind of the branches and the nerve nociceptors spread out. So that's going to be your target. And as you can see here, it's just an artist's rendition of the sinovertebral nerve, the basivertebral nerve, and how it spreads into the vertebral body, and provides nociception of the bone. And you can see just an axial cut here. Here's an MRI from, hang on one sec, I'm going to move you guys. There we go. From the Journal of Pain Research, it just came out. So you can see here, this is a T2 weighted image. Why is it T2? It's because the fluid has a higher signal intensity. And you can see the vertebral bodies here. You can see the entry of where the basivertebral nerve and vascular supply is in the posterior aspect. And you can see in these vertebral bodies. I guess if we were looking at this MRI, this is pretty much a normal disc. This is a degenerative disc. You could argue this is an annular tear, and then you can see the vertebral body down here. So anatomy is key. And the whole thing about the end plates, you know, a lot of times when we look at low back pain, when we evaluate it before this kind of thought process for the BVNA came out, you know, it could be the disc as the source of pain. It could be, you know, the herniation causing a compression on a nerve root being the source of pain. It could be the stenosis causing the pain. But we never thought about the end plates as a source of pain. So we do know recently that these end plates are highly susceptible to injury, of course, degeneration after trauma, fissuring, swelling, and inflammation. And there's actually, and I learned this as I was preparing this, there is a phenotypic marker of vertebral pain noted on MRI images classified as modic changes. In the beginning, you know, we would read MRIs, talk about MRIs, and they say, well, there's modic changes, modic 1, modic 2, and modic 3. And a lot of people didn't really pay attention to those other than that there were these changes. Now, it's important now as you're looking at your MRIs and you look at these modic changes, because now our attention has been brought to them, that there's 3 different types of modic changes. And it's real important when you're looking at MRIs. A lot of times I always focus on T2 weighted images because I'm looking at for annular tears, but haven't spent a lot of time looking at T1 weighted images. And so this brings to light that we need to look at T1 and T2 if we notice modic changes, because there's 3 types: modic 1, modic 2, and modic 3. Now, type 1 modic changes are end plate disruptions, fissuring, degeneration, and active inflammatory end plate changes. So you have a decreased signal intensity on T1s, and you have a increased signal intensity on T2s. So you got to look at both T1 and T2 images. Up until I started talking or learning about modic changes, I honestly never really looked at T1 weighted images. Now, T2, type 2 modic changes, you have a higher signal intensity on T1 and T2 images. And modic type 3, you have lower signal intensity on both T1 and T2. But for this particular procedure, you're looking for type 1 or type 2 modic changes because those indicate that there is some sort of inflammation going on, some edema, And this would be the main things you look for on MRI findings as you're trying to interpret this and trying to determine where you feel like the patient's pain is coming from. This is just an artist rendition of type 1 and type 2. So A and D are type 1. So on a T1 weighted image, because there's low signal intensity on fluids, you see low signal intensity at the end plates. On T2, high signal intensity. Type 2 are B and E. So you see high signal intensity and on T1 and T2. And then type 3 are C and F here. And this is more fatty infiltration. So this is one that we are not interested in. Type 1 and type 2 are the ones that we are more interested in, especially type 1, since this type 1 changes indicate more inflammation, and patients typically fare better with this particular procedure. So you can see here, A and B are type 1. They're low signal intensity on a T1 weighted image, high signal intensity on a T2 weighted image. And type 2 are C and D. You can see a high signal intensity on both of these. So next time, if you're not used to looking at MRIs, I never really was trained in reading MRIs until I met Joe Fortin. So does everyone know the Fortin finger test for SI joint pathology? So Joe Fortin is actually a physical medicine rehabilitation pain management physician in Indiana. And he came and visited us in Lubbock back around 2001. And if there was one thing that perhaps Dr. Rax and Dr. Raj didn't train me to do, was to read MRIs. It wasn't big back in the early 2000s for us. So Dr. Fortin, or the Fortin finger test, helped me learn how to read MRIs. So that's key. Make sure you read your own MRIs and not just rely on the report of the radiologist. Because on rare occasions, I've actually found things that the radiologists didn't see. So it's very interesting. They're board certified and I'm just an anesthesia pain person. And I found something that they didn't. And sometimes I have to have them reread it to confirm that they can see what I see. So type 1 and type 2 modic changes are really what is important, aside from physical exam, and we'll talk about that when you're looking for patients that could possibly benefit from this procedure. So you got to do a good exam. Everything boils down to the good exam. You can learn how to do procedures, but you can't utilize these procedures unless you know how to do a good history and exam. And it seems like a no-brainer, right? But the number of times I've seen patients that another pain management physician has seen, and the patient says, this is the first time anybody's actually examined me. And it's kind of surprising. Isn't that what we're taught to do? You take a history, you got to do a physical examination. It just fathoms me. So what we're looking for is patients with axial low back pain that could be suggestive of vertebral etiology. So you have to rule out, that it's discogenic. The disc is the source of pain. You've got to rule out whether or not it's a, compression of a nerve root by a herniated disc, or it's axial spine pain from the facets, or if the SI joint. So you've got to rule out all these things before you think about this particular procedure. Now, just as far as, the biochemistry is that the damaged vertebral end plates can be directly related to inflammatory cytokines, substance P, CGRP, and there's actually histologically can be confirmed with protein gene product, positive staining under microscopy. So of course, this was not done in live humans, but it was done, I'm sure, in cadavers. And then once again, like I said, the type 1 modic changes have reported to have a stronger direct association with one or more debilitating severe low back pain. So type 1 is good, type 2, secondary, and type 3, of course, you do nothing for type 3s. Whatever your indication. So somebody with a chronic axial low back pain of greater than 6 months, that is refractory to non-operative treatment for at least 6 months. Like I said, it's real important to go through all your conservative treatments before embarking on this particular procedure or any procedure for that matter. On the MRI, you have presence of type 1 or type 2 modic changes and at least one vertebral end plate. Sometimes that's all you see. There's documented evidence of significant impairments in function. So I typically use the Oswestry Disability Index to assess function. Debilitating pain unresponsive to conservative care. You need to have confirmed skeletal maturity on diagnostic imaging. So this is not a procedure you do on adolescents, whether bone structure is still developing. And then you have a history and physical exams supporting other potential primary sources of pain have been ruled out. You've ruled out everything else. You have a patient with low back pain of at least 6 months duration and type 1 or type 2 modic changes, exhausted conservative therapy, and you feel like nothing else is actually causing their pain. Contraindications, of course, any sort of infection, pregnancy, because you have to use fluoroscopy for this. I have not found anything using CT scans, incomplete skeletal maturity, implantable pulse generators, pacemakers, and defibrillators. I wonder if that might be actually a relative contraindication because, you know, we do RF ablations on patients who have pacemakers and defibrillators. Patients with severe cardiopulmonary compromise because the patients have to be prone. And also you need to look at your target to make sure that the ablation zone is not less than 10 millimeters away from sensitive structures, mostly like in the posterior part of the vertebral body. So that's key because those modic changes can be along the entire vertebral body. It could be anterior, but if they are very posterior and there's the chance that you place the RF, bipolar RF probe on the back part of the vertebral body and that you can potentially injure the cauda equina. So that's real important. If it's less than 10 millimeters away or a centimeter, you cannot target that particular patient. Other considerations, morbid obesity, and this is mostly due to your tools that you have in the kit. Patients with symptomatic spinal stenosis or radicular pain is the primary source of pain. So that's why I said it's real important to rule out all those other things. Patients who may have osteoporosis or history of compression fractures, metastatic disease, malignancy, and also bleeding. So you need to make sure that all your ducks are in a row before you attempt this procedure. So this is your kit. And I promise I'm not making all these blue lines. I don't know how those got there, but I don't know if you can see them, but I can see them. So this is your kit. You've got, these are your trocars. You've got a diamond tip, you have a bevel tip. So those of you who are familiar with doing vertebroplasty or kyphoplasty should have absolutely no problem doing this procedure because the entry is almost identical to doing kypho and vertebroplasty. This is your curve. This is what you lesion through, and this is a straight stylet. So this is your kit. Like I said, I have not been trained on this, although I hope to be soon, but this is your particular kit. So if you have any questions at the end of this on the kit itself, I'm going to have to refer you to the Intracept or the relevant website for that, okay? This is your RF generator. It is temperature controlled, it's bipolar. The cannula, this is the cannula you put through this particular device here, the curved cannula assembly. And essentially you lesion for 15 minutes at 85 degrees centigrade when it's positioned properly. So positioning. So here you can see it's a transpedicular approach, going through the pedicle and then inserting the cannula into the middle of the vertebral body. This is some radiographic imaging from a recent article a couple of years ago. You can see the docking of the trocar on the lateral aspect of the pedicle. And here's your lateral, then tap, tap, tap. tap, 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 tap. So now you're into the vertebral body itself. Step 3 is placing the RF probe. So here is the cannula. This is the RF probe going through the cannula. So the distance you need to be, if you divided the vertebral body anterior posteriorly by thirds, the tip of this probe needs to be at the junction of the posterior 1/3 and the middle 1/3. So you're in the posterior aspect of the disc, the vertebral body, because that's where you will lesion the trunk of the basivertebral nerve. Okay, so that's what you're lesioning. You're not lesioning out here, but it's a bipolar lesion. Here's a transperpendicular approach. You can see the tip of the cannula here, placing the probe, and where you would be to lesion. So your AP is just like the views that you get when you do vertebroplasty and kyphoplasty. And you're trying to get to that cannula towards the middle so that you can lesion here. And if you've got, what you look for, of course, is the modic changes. So if you see modic changes at the L3-4 disc, you'll have to lesion at L3 and L4. L4-5, the same. So you lesion in the vertebral body where the modic changes are. 15 minutes at 85 degrees, ablate basivertebral nerve. Now, what are some adverse events? Most commonly reported self-limiting. The events are, of course, a temporary exacerbation of low back pain. It could be incisional pain, minor or transient radiculitis, which is typically self-limiting and gets better. They've seen non-permanent lumbar radix, nerve root injury, or motor sensory deficits that return over time. Now, there have been a few, not a whole lot. I think there were in one of the studies, the pilot study, there was one vertebral body compression fracture. There was device related, not sure exactly what device related. And there was also a retroperitoneal hemorrhage. So that's kind of interesting. I cannot tell you exactly how that happened, but obviously something must have gone through the anterior vertebral body for that to occur. But they did not expand on that. Now, of course, we want to see some studies. Here we go. This is the SMART trial, which actually just came out in 2020. They looked, this is a 5-year durability. So they wanted to see what the longevity of this procedure is when it came to pain relief. Now, there were their primary endpoint was the ODI. Of course, here they reported VAS, but it was really the ODI, not the VAS. There are 133 treated patients, 117 successful, 110 were available for review, and the mean follow-up was 6.4 years. So as far as the ODI, there was about a 26%, well, actually a 26 number reduction in the ODI from 43 down to 17. VAS, it was 4.4 at 5 years. You can see on average at baseline of 6.73 and decreased to 2.35 over 5 years. And 1/3 of the patients were pain-free at 5 years. And you kind of ask yourself, well, as with most pain patients, you're kind of like, well, wait a minute. They went 5 years and the patients did not have any other procedures. There was a small subset of patients that did have other procedures, but the physicians felt that it was not secondary to the vertebral in-plate pain, that the patients may have herniated a disc and were treated with epidural steroids specifically for radicular pain, or they were treated with SI joint injections for SI joint pain, etc. So some of these patients did have other procedures, but the study investigators did not feel it was secondary to the vertebral in-plate, or what they felt the source of pain was for which the BVNA was used. This was the Intracept study, which is a 24-month study. This was published in the North American Spine Society Journal just a couple of years ago. There was 140 patients. They were randomized to 66, which had the BVNA or the ablation. There were 74 as standard control. What they looked at was, of course, the control group, which you can see in the light blue. You can see the treated group in the dark blue. And what they did was they allowed these patients to cross over into the BVNA group at 6 months. So as you can see, their pain scores for the control group did not really diminish any. And so I'm sure they felt that it would not be humane to let them continue for 2 years without treatment. So they allowed them to cross over. And then you can see the hatched gray line was this crossover group of 61 patients whose pain at 9 months and 12 months was about equal to that of the group that were treated initially. So there was improvement there. This was a prospective single-arm study, a 12-month result published in the NAS journal. And there was 47 treated patients. There were 46 at 3 and 6 month follow-up and 45 at 9 and 12 month follow-up. The ODI was their primary endpoint, and you can see there's an improvement in the ODI of 32 points from baseline of 46. The VAS, there's a mean reduction of 4.3. And in these studies, they based meaningful improvement as a 2 number decrease in the VAS. So if it went from 8 to 6, that was significant, 7 to 5. I believe there was a study that showed a 2-point improvement in VAS was comparable to good relief. 69% of the patients had greater than 50% reduction in pain, and 38% of those patients were also pain-free at 12 months. So looks like a good procedure. They took all the studies, the SMART study, the Intercept, the one we talked about, the crossover, and the single arm. And this is just a graph showing with these 4 particular studies that there were about equal reduction in the VAS score over time. Of course, this is a 5-year arm. So there is improvement. And conclusions. So this is a relatively new procedure. In fact, I could not tell you how many physicians in the United States are actually doing this procedure. I think the one difficult thing in the US is that our insurance companies and Medicare has not developed codes for this, or we don't have any codes to bill for it. So a lot of the physicians who are doing it the patients are having to pay cash, and the company is being very selective as who they are teaching. And, you know, it's real important to, like I said, we have a lot of tools that we can use in our toolkit, but we have to make sure it's the appropriate tool. You can't screw in a nail or a screw with a hammer. You can probably pound it in, but you need a Phillips head screwdriver or a regular screwdriver to screw in a nail. So make sure you do a good exam. Well, take a good history, do a good exam, come up with a differential diagnosis, and establish a treatment plan. And always, for anything, go from conservative with your physical therapy, occupational therapy, rehab, medications, before you start introducing interventions, because an intervention is not going to work if you do it on the wrong patient. Please know your anatomy, not only just skeletal anatomy, ultrasound anatomy, fluoroscopic anatomy. You got to know the anatomy of where you're doing this procedure, because unfortunately, you know, you're going to have a complication at some time in your life, and you need to make sure that at least you have a working little puppy. I don't have my cats, and I locked them out of the room. That if you have a complication, that you're not turning to pick up the phone and saying, you know, calling Jose Luis Campos and saying, Jose, I was doing this and what's happening, or Miles Day. You know, you need to kind of think for yourself. So those are my conclusions, and here are the references. If you go I will, if there's some way, Jose, that I can email you this presentation. Some of it is taken from this first reference up here. This book chapter here goes over the procedure really well. And a lot of the other information came off the Relievant, which is the company who makes the Interceptor, the BVNA. So if I can get this to you, perhaps you can share it. Just if you use anything, give the right credit to the websites and what have you. So I'm going to stop sharing, and I know sharing is caring, so I'm back on here. So if anybody has any questions, or if anybody has performed this procedure already, I don't know, is it available in Brazil yet or South America?
No, it's not yet, my friend.
Yeah. So
Yeah.
You know,
We are interested in that procedure, but we don't have yet. Congratulations for your presentation, Miles.
thank you.
Very, very good.
Yeah, it's a very interesting procedure, and you know, I'm kind of one of these folks or physicians that like to see how things pans out, because a lot of times you get new technology, everybody in the US jumps on the bandwagon of doing it. They start doing it, they do it for the wrong reason. The results in the real world are poor. And then insurances was like, well, the results are poor. We're not going to pay for it because people are doing it for the wrong reason. You know, just because you have technology doesn't mean you need to apply it immediately. So I kind of a wait and see kind of person. I know the 5-year data looks good, but a lot of times, well, they're all in controlled situations, and every person I talk to who does this, they're like, oh, works great, just works great. It's like, well, that's great. You can tell me about your successes, but can you tell me about your failures?
Yes.
Who did it not work in, right? Because that is key information. I know if those of you know Kiran Patel, she did this procedure in Carson Daly. And I don't know what the results were, but it made a lot of splash on Instagram and on social media. And people were asking about it because Carson Daly had it. So make sure you pick the right patient, okay? You're going to have better successes with anything you do in the right patient.
I agree totally with you, my friend. I would like to know a little bit more about the indication, Miles. You said many things important, and I want to know if you had, if you have some steps, like for example, if you have many levels in MODIC or important ones, if you indicate or make antibiotic therapy before.
Mm-hmm.
And if you make an anesthetic local injection intradiscal before the procedure to find the level before you did the procedure, you make this procedure, please.
Jose, those are great questions. I think the key thing is patients who have had low back pain, axial greater than 6 months, and you've ruled out all other potential causes. You've ruled out the facets, you've ruled out the interspinous ligament, and this is not necessarily discogenic pain. It's not the disc as the source of pain, it's the end plates as the source of pain. So discograms will not help you because you're not looking at the disc as the source of pain. So we always say, you know, axial pain goes vertically, discogenic pain goes horizontally. So this is like pain in the middle of the back greater than 6 months with at least one vertebral body level that has either a type 1 or a type 2 modic change. And you asked a great, or you mentioned something that's I haven't really looked into about patients with modic changes and treating with antibiotics. I know probably about 5 or 6 years ago that there were a few papers, maybe more, that came out talking about treating modic changes with antibiotics, and there had some success, but nothing that I've read talks about, you know, treating first with antibiotics. I think some people believe in that or don't, but this is really the end plates of the vertebral bodies as the presumed source of pain, not the disc itself. So hopefully that answers your questions there, but those are great questions. It's one of those things you've got to rule out everything else before you venture off on doing the basivertebral nerve ablation.
And Miles, I understand about your follow-up. You don't have a fracture after this procedure, if I understand you well. But you have noticed if this procedure can accelerate the disc degeneration?
That I do not know. That I do not know. I guess there was, in the study, there was one incidence of compression fracture. And I'm trying to think, that is all I can, well, I guess one of the things they did mention was patients with osteoporosis who already had poor bone structure, and they recommended not doing it. And I think part of that is because you're, creating a channel through the pedicle and into the middle of the vertebral body. And I guess there is the potential, and I couldn't tell you percent-wise, that you could cause a compression fracture because of that. But I don't know if any, studies specifically looking at that. And I think there's a question that says, did you hear about the use of interosseous injection of PRP? Edison, I have not, but if you can tell us a little bit about that, if Jose doesn't matter, that would be nice.
No,
Sir, yes, sir, Andre.
Yes, thank you so much. It was a great pleasure, and it's a privilege hearing from you. I think it's well clear that it's not for discogenic pain, it's for a kind of vertebrogenic pain.
Correct.
And I'm wondering about the selection, because we don't have, in my opinion, comfortable and reliable diagnostic block for this kind of patients.
You are correct.
There's no discography and nothing we can use for a good selection except the clinical picture.
Correct. And the clinical picture and the MRI. Correct.
So do you think it's feasible, for example, to inject local inside the vertebral body?
I'm sure it's possible if you could get a needle that you can place through the bone.
Through the bone, yes.
Yeah.
These trocars, I'm presuming, are probably about the size of the trocars you use for
vertebral
vertebral
yes. Yeah.
So,
13 gauge.
In the same
Yeah.
entrance 2 times.
yeah. So it's when I first heard about this, I was very skeptical, because it's like, so you're trying to tell me that you have to have 6 months of pain, modic changes, and failed conservative therapy, and then you put this big old trocar through the pedicle, and then you kill a nerve. And it's like, that's why I've kind of sat back wanting to see how things have panned out. And a lot of the studies, coming out nowadays are real world studies. They want to see how this is working in the real world. But when I've looked at real world studies for anything, especially neuromodulation, the real world physicians are the ones that wrote the paper for SCS. So to me, that's biased. So it's, I think it's one of these procedures that you have totally ruled everything else out. You've done perhaps, your medial branch blocks, no relief. You've maybe ventured out looking at the disc as the source of pain, no relief. And this is what you're left with, essentially. There are some people that just totally believe in this procedure, that it's the next best thing to sliced bread. But I think everybody who is here kind of takes a more pragmatic approach and kind of like, well, I'm not so sure based on these current indications. Possibly over time, we could, develop better techniques. I don't know. Can you selectively block the siniovertebral nerve? I don't know if that's possible. I'm sure somebody could say, well, I put local anesthetic in the back part of the epidural space and the patient got better in the anterior epidural space.
There were two videos I saw at NAS, and one of the physicians told he did that, put the local anesthetic in the disc. And what they said was just about the exclusion criteria with the physical exam and see the image, and never proceeded in someone who did a spine surgery, just to avoid those things. And what they said also was about the worst results with L5S1. And to observe the sacral slope and the spinopelvic parameters. But I know nothing about it, I just read it.
Sure.
And saw the videos.
Not necessarily. That's great information. I mean, like I said, I'm kind of like reporting things here, and anybody who has seen or read anything, I guess, Andre, you could use a discogram to rule out the disc as the source of pain. In patients with motic changes. But I haven't read anything, at least, the indications, and when this procedure is developed, that's a necessary thing. But like I said, when it comes to new procedures, I just take things real slow, because when the IDET came out in '98, that was a cool thing. Everybody would do an IDET. Then the disc trode came out, Philip Finch with radionics, and that went nowhere. For discogenic pain, then you got biaculoplasty. I think you guys still do biaculoplasty, correct? Disc RF. That doesn't get paid for in the United States. I think that's kind of the killer of all new procedures in the US, is insurances and CMS not paying for them. And then it's like, okay, what's next? So.
Okay, Miles,
Sir?
when you have one level in Modic, one level, just one level, for each level, do you need to make it above it and under that level? Two procedures?
No, you just do it, from what I've read and looking at the indications, you only have to have one level. So if you have a Modic 1 or Modic 2 changes in the inferior end plate of L4, you would just do a BVNA at L4. I didn't read anywhere where you would have to go to the superior end plate of L5 to treat it, because there's no Modic change. So it's just one Modic change, one RF. I didn't, looking at some of these, I've seen some pictures of people doing, if you've got Modic changes at 3 levels, then you do, 3 trocars into each one, really not knowing, which one's symptomatic. Which would be a big question. Now, how do you know it's, the end plates of 3-4 rather than the end plates of 4-5? I don't know, because like Andre was asking, how do we diagnose it? Can you diagnose it with local? It's just, I hate to use the word carpet bomb, but anything that's got a Modic change, you put a trocar in it and you ablate it. And really, what's the generator? It could only be one level, but you're putting a trocar in the other levels, and putting a hole through the pedicle, potentially creating a compression fracture or a pedicle fracture. So I think there's a lot of questions that are still out there, and I guess those would be left up to when you go on the website, there's a guy named Brian Durkin. He's up in New York City that does quite a few of these, and he's had one done on himself. So he's a firm believer because he had one. And I'm glad it helped him out. Kiran Patel's on there, and a couple other guys that are on there. So I think a lot of those questions could be answered by somebody who has a lot of experience.
Okay. And which kind of recommendations do you have after this procedure for your patient? how many days to total rest or to start or begin the exercise again?
Well, Jose, that's a great question. And I honestly don't have an answer for that, having not done it. Actually on the website, really not looking at a rehab for that, but I would presume it might be similar to a kyphovertebral because you're putting a hole through the pedicle, but it really didn't mention post-operative or post-procedural limitations. I think it would possibly be based on what sort of bone structure the patient have. It didn't say anything about the procedure destabilizing the vertebral body itself after an ablation, so I would have to rely on doing a little more research. I apologize for not looking at that, but that's a great question. So sorry I don't have a good answer.
It's okay. Takeda, tem alguma pergunta para nós aí, meu amigo? Tudo bem.
Tudo bem. Hi, Professor. Good evening. Great presentation. Thank you for your time. I just want to know if you recommend, or the website recommends, some kind of adjuvant medicines or drugs to these patients after the procedures.
I think it didn't mention anything, but I think it's just based on the patient themselves. It didn't mention anything about neuropathic. I'm sure different doctors have different ways they treat post-procedural pain, but it did not specify that this was an extremely painful procedure that you had to prescribe large doses of opiates treating it. So I'm sure it's just symptomatic, soft tissue. I presume there could be, non-steroidals, there could be, muscle relaxants since you're having to go through some muscle to get to the target. But I think it's probably patient, specific. We all know we've got patients that can tolerate a lot of discomfort and a lot of them that can't tolerate any. So I think it's just symptomatic treatment and, careful and watching them closely.
Perfect. Thank you so much.
Thank you for your question. Appreciate it.
Alguma pergunta a mais aí? Andrezão, Cecília, Sandra, tem alguma pergunta? Deixa eu habilitar seu microfone aí. Veja aí. Deixa eu ver se eu estou conseguindo. Não estou conseguindo, minha amiga. Aqui, ó. Vai habilitar agora.
Você já tinha perguntado o que eu ia perguntar. José had already asked you about what I was thinking. If we have two end plates, because normally when we look to the modic sign, generally we have in both end plates, superior and inferior. So I was wondering if we had to do in both levels, superior and inferior too, but you answered him already about it. Yeah. And I was just thinking if it's feasible, also because of the complications, because you have to place the trochanter in different levels. So if complication could be a fracture,
right? You
have to think about it. So
yeah, they recommend, well, they specify that if you have a patient who has modic changes in both end plates, inferior and superior, that you would do the procedure on both of those vertebral bodies. So,
and Miles, what do you think about monitoration in the epidural space with one thermometer there to measure the temperature in this epidural space?
I presume when they did the studies that they looked at as long as you are 10 millimeters anterior to the posterior end plate or the posterior vertebral body, that you're in a safe zone and that you wouldn't have any dissipation of heat. You back in about 2000, when they came out with the disc trode, I don't know if any of y'all go that far back, but it was basically a technique to lesion the annulus in the posterior part of the vertebral body. And you would place a needle into the posterior annulus, thread the heating probe into the posterior annulus. And if you came in from the right side, on the left side, you would take another needle and you would place it right on the disc. And as you lesion, you can measure the temperature of the disc to see how hot it would get, as kind of as a safety measure when you were lesioning the disc itself, the posterior annulus. That has not been mentioned in anything that I've read. And talking with other people, I don't think anybody does that. I think they feel like there's enough insulation in the bone that if you're in the proper plane, you're not going to have an increased temperature in the epidural space or the canal to cause any harm to the cauda equina.
Ok. Outras perguntas, pessoal? Como é que estão aí? André, Cecília, Taqueda, tudo bem?
Opa, tudo bem. Acho que é só.
Alexandre Miles asked why I don't can use cement like vertebroplasty in this procedure. I waft there.
You know, that's a good question. I guess that's a good question for the, well, I guess one thing, the temperature when they do the RF is 85 degrees centigrade. Polymethyl methacrylate, I don't know the temperature that it gets to, but
70.
Yeah,
probably.
so, yeah, that's a real good question. Why can't you do it? I don't have the answer to that. That's why these forums are very neat, so we can have that discussion. I don't know.
Yeah. Okay.
But I think too, you know, when you're, if you have a patient with very dense bone, you know, and those of you who do vertebroplasty can answer this, you know, how difficult it is to inject that cement into dense bone, rather than an osteoporotic fracture where it just kind of like butter. So I can't tell you if you can create a big enough channel to do it in a bone that doesn't have a fracture in it. Andre, do you have any comments on that, or those who do kypho or vertebroplasty?
Kypho or vertebral?
No.
No.
Okay. Okay, Miles, once more, I want to thank you very much to come to sharing your time with us. You are a very, very important person for us. Thank you very much.
Oh, my pleasure.
Yes.
I always
We
enjoy.
wait you in August in Brazil.
Yes,
In
sir.
our Congress.
I'll be there, bright-eyed and bushy-tailed, and ready to dance.
Yes, yes.
And some cachaça.
Yeah,
Yes.
perfect.
Well, y'all have a real good evening. And Jose said y'all don't eat supper till 9 or 10, so I'm about to eat supper too. So I'd eat dinner. But it's always been a pleasure. Thank you, Jose, and everybody who's sponsoring for having me. I sure do appreciate y'all.
Bye. Thank you.
All right.
Bye.
Thank you.
Okay.
Bye.
Thank you, professor. Thank you again.
Thank you.
Pessoal, eu vou só falar aqui para vocês, antes da gente sair totalmente aqui, que o sorteio para a inscrição do congresso foi para Yara Maria Moura Batista Pereira Serra Lima. É só entrar em contato com a Kátia, ou a Kátia também, que é a nossa secretária da Sobramid, vai entrar em contato com você. Parabéns pela inscrição do congresso. Obrigado, meus amigos. Ótima noite a todos aí.
Pessoal, boa noite.
Um abração.
Boa noite.
Tchau, Ceci.
Valeu, Mil. Valeu, meu.